I think the thing to understand is that when you come in and see me, we both want the same thing. You want to get as much information as possible and as much assistance as possible in managing your disease. And I want to get as much information as possible about you and as much, manage your medications and all the other things that we need to do with Parkinson's as well as we can. The complicating factor is that these days we have less and less time to spend. So what I want to do is talk about how you can make best use of an appointment, okay? The first thing I think is to be prepared. From my standpoint, one of the things that's most important is that I know every medication and every supplement you're taking. I need to know the strengths and how often you take it. With your Parkinson's meds in particular, that's absolutely key. With carbidopa, levodopa, we're usually pretty good. I can say, is it the yellow tablet, is it the blue tablet, is it the purple tablet, and I can figure out what strength it is. With Stalevo, not so much, because they're all football-shaped and kind of an orangey-brown color. And if you come in and say, well, I take the little white tablet for my blood pressure, I have no idea what that is. And it is important because drugs tend to have interactions, and I want to make sure that I'm not giving you something that's likely to interact with something else you're taking. The first time you come in, bring everything. Times after that, if I haven't seen you in a couple of months, something may have changed. So if you bring an updated medication list, that's also very helpful. The other thing that's useful is to bring an outline of your medical history, partly relating to why you're there to see me, but also all the other little things that have happened in your life, illnesses, surgeries, operations, things that may have happened. Because when I see you at the first visit, I want to find out everything about you. But I want to spend the most time on why you're there to see me, which is your Parkinson's. But I need to know all the other stuff. So if you bring me a list, a description of your history, then I can run through that much more quickly and much more efficiently and have more time to spend on the main event. When you see a physician, it's not always the most relaxed time of your day. So be prepared to take some notes of things that I may tell you, or have someone come with you who can act as sort of an auxiliary memory and who can either take notes or remember the things that it may be hard for you to remember. And this I learned when I was a new mother. And I would take my daughter in for something, and I would leave, and then I would call back and say, I'm calling my neurotic parent capacity. I don't remember what he told me. So I learned very fast that you really have to write down what's happening, what's being told to you, and what you need to do. And you have to understand it. The other thing is to make a list of the questions that you have for your doctor. And I think most of you heard Dr. Brandenburg inside in the morning session talking about how to ask the questions. And if you're asking about, well, I'm getting cramps or my shaking is worse, when does that happen? So think the question through. If you have a funny movement, when does it happen in relationship to your medication doses? Because that will help me figure out what the problem is and what we can do about it to try and make it better. We try to answer all questions. Sometimes we simply don't have time. Now, most of the time, my patients are very understanding, and I run over and they don't mind too much. Some patients have been known to call and say, is she running on real time or chance time? And if it's chance time, they know that they don't have to arrive exactly on time. So again, that can be helpful if you want to find out if you need to sit for an hour in the waiting room or if it's only going to be about 20 minutes, call ahead of time. The other thing is that if you have a lot of concerns and questions, call ahead of time and ask if you can have a longer appointment, and that takes the stress off everybody. I know that you have a lot of concerns, and I know I have time to address them. The initial visit is what was known as the consultation, where you come in, I see you for the first time, and I usually don't know anything about you. Records may have been forwarded to me, but to some extent, I like to look at the records after I've seen a patient, because I want to form my own unbiased opinion, unbiased by what anybody else thinks. So that and then if I can go through your records and it will agree with me, disagree with me, give me added information. But a copy of your medical records is a really important thing at some point. Typically, an initial visit will last about an hour. Oftentimes it'll be an hour and a half, and sometimes if I have plenty of time and it's at the end of the morning or the end of the afternoon, we'll just go on and on, okay? And with a brand new patient, particularly someone who's been diagnosed for a long time and has a complicated course, I like to have that extra time because there's a lot of stuff that we need to sort out. What happens at the initial visit is that's when I try to figure out what's wrong with you and begin a plan of treatment. One of the things that happens is that by the end of that visit, I come up with what I think is a diagnosis and a plan of treatment. Patient goes home, gets on the internet, calls me up and says, but you didn't talk about this or that or the other. The thing to remember about it is that the whole time that I'm talking to you, I'm forming something called a differential diagnosis. Differential diagnosis is what we're all trying to do. What are the various things that might be producing your symptoms, and how do I narrow that choice down to one or two or three things that we need to direct our attention towards? So if you come in and you've got right-sided Parkinson's and I haven't talked to you about a brain tumor, that's because brain tumor is incredibly rare as a potential cause of Parkinson's. I've seen one patient in my whole career who came in and had a metastatic tumor from a lung cancer that was producing their symptoms. But it was atypical. It was a very rapidly progressive course over about 3 weeks with no other possible cause. And so that made me think, what's going on? We did a brain scan and we saw it. But the things that I don't mention are not necessarily things that I haven't thought about. They're just not relevant to the situation. Because if I went through the whole differential diagnosis of tremor, we would be there for hours and hours and hours, and I would have you totally discombobulated with the amount of information that I would be giving you. So we try to narrow it down to the most likely possibilities, okay? Planning treatment is usually a decision that I like to make with you. I see my role as proposing medications or physical therapy, occupational therapy, speech therapy. And your role is to kind of go through it with me and decide, is this something you want to do at this point or not? If you don't want to do it, why not? How can we sort this out to come to something that is comfortable for both of us? You are a very integral part of your treatment, and you need to understand it, you need to be comfortable with it, and you need to be able to talk to your doctor about it, okay? If I come down in a very authoritarian way and say, you will do this, well, if you're like me, I immediately turn back and say, no, I won't. And I want to talk about it first before I make a decision. I see treatment of Parkinson's as like a big circle with every member of the team in it. And rather than you being in the middle and everybody talking at you, I see you as part of that circle so that you are just as important as anybody else. And it is a team approach. It has to be. That's the nature of the disease. The third important part of the initial visit is that we get acquainted. Medicine is a narrative. It's not a series of points. And one of the first things that I was taught as a medical student in about 1968, and it seems an incredibly long time ago, was that you are not treating a disease, you are treating a person with a disease, and you have to know that person. And I think that's terribly good advice, because everybody is different in their nature and their character, and everybody's disease is different. I think one of the speakers, again, in the question-answer session was talking about how every patient with Parkinson's is different. And they are, and that's one of the things when I sit on my side of the desk that makes it fascinating, is that one person may come in with one issue, another person may come in with Parkinson's, but a very different issue. And then take it in the context of each individual's life is how we begin to plan out the appropriate treatment, okay? You and your physician are going to have a long-term relationship. And I have patients who I've been seeing for 15, 20 years. It's really important that you're comfortable with the physician that you're dealing with. If you're not, if you don't like the way they work, make a change. Find somebody with whom you are more comfortable. Some people love the way I work. I'm a bit sort of sloppy and messy, and I spend a lot of time, and I'm not very cut and dried. Other patients prefer somebody who is much more cut and dried, and I would encourage them to find a physician who fills that need, because you are going to be with them for a long time. Parkinson's, at least for the foreseeable future, is not going to be cured. It's going to be treated. So be comfortable or make the change. How can you find a physician who's going to work for you? I do believe that people with Parkinson's need to be managed by physicians who are very familiar with Parkinson's, and most often it's a movement disorders trained physician. If that's not accessible to you, you can always call one of the national organizations like APDA or NPF or PDF and see if they have a referral to somebody in your area. Sometimes what you need to do is go every now and then to a major center and then come back and work with your local community neurologist. I think things are going to change certainly in a lot of places, particularly in Europe. Now they're doing something called distance medicine, where you do it through the computer and Skype, where the physician who's at the Parkinson Center sits and asks the questions, and you're there in front of them, and they can see exactly what's happening and what's going on. And this, I think, is going to be something that we will use increasingly, because there's just not enough docs out there who really treat Parkinson's. And I think it's true for a lot of subspecialties. Follow-up visits. And this is where we assess your progress and we decide between us what the next step is going to be. Do we stay with what we're doing, or do we want to move on to something else or make a change? Typically, these visits will last 15 to 30 minutes, sometimes longer and sometimes shorter. If you come in and say, boy, I feel terrific, everything's great, nothing's changed, and I watch you and nothing seems to have changed, I'll say, out of here, come and see me in 4 to 6 months. And usually what I do is make sure that you have scheduled an appointment before you leave so that you're on the book so we can remind you. Don't be afraid to have a very open dialogue with your doctor. That's the way it's supposed to be. You should be able to ask any question that you like about anything that you like, and I should be able to answer it, or if I can't answer it, at least say, okay, I can find that out for you, or I think this is something that you better discuss with your internist, because I don't think it really has to do with what I treat you for, and I just don't know enough about it. So that kind of dialogue is important. I need to know also the kind of things that are going on in your life. You know, are things good at home? Are there problems? Do you have a kid who's, you know, had some issues? Or, you know, are there financial problems? I need to know these things because they're all very relevant to your progress. Sometimes patients come in and they look awful, and they've been doing very well. And then I want to sit down and say, what's going on? And I need for you to be comfortable enough with me that you're willing to tell me, because some of these things are personal, private. Do I put them all in your medical record? Absolutely not. There are times I put my pen down and I just sit and listen, and I know what's going on. I know how to make the adjustments. But there are things that I do believe can and should remain private and just between us. There are very strict laws of confidentiality, and what we discuss in my office, I do not discuss outside my office. It's personal. A lot of things, in a lot of ways, we've lost privacy, but I think in some ways we still need to keep it. Questions. Ask questions. I've said that before, and I'll say it again. You have to ask the questions. Some people say, well, this is a stupid question. There is no such thing as a stupid question. There's only stupid answers.
What do you think of Kaiser?
The gentleman was asking me what I think of Kaiser's archived records. I think what is happening, this is the way of the future, is that all medical records are going to be online, electronic medical records. And in fact, I think in 2014, we're going to get fined by Medicare unless we're doing a considerable amount of our stuff on electronic records. The pros about electronic medical records is that ultimately they should be accessible to anybody. I think the final thing that will happen is that you see me in Southern California. You go to Alaska, and you're in a little tiny town in Alaska, and something happens and you're in the emergency room. The doctor there should be able to get on a computer, find your records and say, oh, okay, you've had this, this, and this done. Okay, see, that's done. And that will make for much better and much more efficient medicine. The downside is people can get into your records. And the downside to me of electronic medical records is it takes away from the narrative. So much of it is fill in the blank. And if you don't fit in the particular set of blanks, it doesn't work. And that's what I don't like about it. And that's why I keep saying it is a narrative. It's not a series of point to point to point. And you have to know the whole person. So the Kaiser system actually I think is very efficient. And I think they've done it extremely well. Have I had personal experience with it? No, but I know docs in Kaiser, and they really, really like it because they say they can get any information that they need from the patient standpoint. So I think it's probably going to be a really good thing. It's just the little problems have to get ironed out, and the lack of people think that a paper record is much more open to invasion. I would tell you that I think it's completely the opposite way. If I'm at home and bored in the evening, I can't just go and open a chart and see, gee, I wonder what's wrong with them, if it's a paper record. If it's in the hospital and somebody's in and I want to figure out what's going on with them and they're not my patient, it's a little more intimidating to walk up to the chart rack where the nurses are, pull the chart out and go and have a little read. Somebody says, what are you doing? You know, what's your involvement with this patient? And if you don't have one, the trouble with electronic medical records is I can go at home and I can just browse my way through and say, gee, yeah, I wonder why they're there. Let me take a look and see. And they can scold me after I've been there. I have never done this, but they can't stop me from going there. And that's the big issue that I don't know how we'll resolve. But somebody will figure it out who's more technological than I am. Now, before you leave any appointment, one, be sure you understand what you're supposed to be doing and what's been recommended. And two, make sure that you have a follow-up appointment scheduled. These days, we all do appointments on a computer-based program, so I can schedule up to a year ahead of time. So if I'm not going to see you for a year, let's get you scheduled, 14th of February next year, fine. And the other thing really is understanding what's been said. So often, well, not so often now, but in prior days, I would say, well, we're going to do this, this, and this with your medication. And then a patient would call me back an hour ago, and he said, you were going to do this, this, and this, and it's not exactly what I said. I find now that if I have a complicated medication regimen, I like to write it down on my prescription pads, which have copies, so that if you call and say, I don't understand, I've got an exact copy of what you're looking at so I can explain it to you and make it clear. And that's been really helpful. It's, I think, cut down on a lot of people having to call back because I didn't make myself clear verbally. I want to talk a little bit about the hospital. Hospitals have changed, in case you haven't noticed. There are now a breed of physicians called hospitalists. All they do is take care of inpatients, and they're in the hospital 24/7. It's enormously helpful because, one, they are there 24/7, so if something happens, the nursing floor pages the physician in-house who comes and sees you. In the old days, what they had to do was call your answering service, who would try to get a hold of you, and you would have to call back and then figure out what was going on. And in an urgent situation, that's not very productive. So the hospitalists have been very, very helpful. The disadvantage of the hospital is they don't know you, you don't know them. You're dealing with a totally different cast of characters. And so you have to be prepared. People who, with Parkinson's, are never admitted to hospital with Parkinson's as a primary diagnosis. It is a secondary diagnosis. So they're really interested in your broken hip or your perforated ulcer or your stroke, and they're really not so interested in the Parkinson's. So it is key that you have a printout of all your medications with the strengths and the exact times that you take them. Why does the time matter? If you take your medicine at 7 o'clock, 10 o'clock, and 7 o'clock in the evening, that's 3 times a day. If you tell a physician, a hospitalist, I take my medicine 3 times a day, he will write TID. In hospital speak, that's 3 times a day, and hospital times are 8, 2, and 8. So you won't get your medication when you need it. So if you bring the list with you, or somebody brings the list with you, and make sure that the times that you take it are carefully written down, then you'll get your medications when you need them. And I think that's one of the most important things to take home messages today, is be prepared for hospitalization. The other thing that you need to get ready for is any kind of emergency that may happen, because oftentimes you'll have a fall at home, break a hip, and be transported into the hospital. You might have chest pain, and the paramedics will come and take you into the hospital. And there are 2 key things to know. One is ICE, in case of emergency. In your cell phone, enter ICE, and under that, a list of your emergency contacts. Anybody that you want to know that you're being taken to the hospital. Paramedics are trained to look for that in your cell phone. Make sure it's there. The second thing is your freezer. It's a very important thing. Get a big Ziploc freezer bag, and inside it put all the documents that you need. Copies of your insurance cards, an up-to-date list of your medications and your drug allergies, something about your medical history, and increasingly importantly, your DPAC, which is your durable power of attorney for healthcare. Again, the paramedics are trained to look in the freezer and see if there are documents there. Now, why do you want to put them in the freezer? Because 1, it keeps things safe. 2, if there's a fire or a flood, it'll probably be okay and the documents will still be all right. And 3, because that's where the paramedics are going to look. So do those, get your DPAC, make sure all your wishes are known so that your wishes can be followed and everybody knows what you want, just in case you're not able to communicate yourself when you first get to the hospital. And I think those are really the sort of the biggest things that I want to tell you. Again, from my side, I really enjoy seeing Parkinson's patients because you do see them for a long time and they become friends. And you get to know about their life and their family and so on and what they're doing and what's going on. And it makes me better able to kind of plan things out for them. And I'm being told I have 5 minutes left and I will be within my 5 minutes. And I think that if you have a physician with whom you do not have a good working relationship, you will not get the care that you need. You will not get the best care. And we all have to be grown-ups. I have to say, look, I don't know that this is working. I think you want something different than I can give you. And you have to say, this isn't working for me. And then either I can give you a referral somewhere else, or you can find somebody else by going to one of the organizations or support groups and finding somebody who might be a better fit for you. So what I'd like to do now is kind of open the floor up for any questions that you may have and any input that you have as to how I can do what I do better. Okay? Sir?
I can always remember or write down everything the doctor says. How do they feel about a recorder being recorded in the appointment?
I have absolutely no problem. I think it's a good idea. Some physicians are much more uncomfortable with that. But I think for the most part, you'll find most people will be pretty easygoing with it. And I think if that works best for you, do it. And particularly because with Parkinson's, it's hard to write. Your writing is small, it's not as legible. When you're trying to do it in a hurry, it gets even worse. So if you want to bring a recorder, no big deal. Do it.
Being in this support group, we talk about doctors a lot. And one of the complaints over the past 2 years that I've been attending it. The doctors sit there and they type in their laptops and everything, and they're so cold and they're not looking us in the eye, and I don't think they really care about me. That's what we hear at the support groups.
Yep.
And the other point was on your freezer bag. We just had a big workshop at our North County Parkinson support group where we got tons of people come. The vial of life. And we all filled out all the information on a piece of paper, stuck it in this vial of life, and we have it on the outside of the refrigerator. So that when they come, it's right there to grab, and we try to, this is a big program that we just finished.
Let me deal with the second part first. I love the idea of the vial of life. And maybe, do you know how we can, who does it, how we can get a hold of it? San Diego Police Department. I'll give them a call because I think that's a really good idea.
The Southern California Caregivers Association.
They have it too?
They have it too.
Okay, that's dynamite. I really like that idea. So if you want to get the vial of life, you can do it through the San Diego Police Department, beg your pardon, or through the Southern California Caregivers Association. Okay, to go back to the first thing, everybody is looking at their computers and they're not paying attention to me. I do not do electronic medical records because I'm a lousy typist, and I was raised in a convent boarding school and we didn't learn typing. I write while I'm talking to you. And I think if somebody's really comfortable with a keyboard and they can type and look at you at the same, talk to you, and a lot of the younger physicians can do that, it's pretty acceptable. If somebody's totally into their thing and you don't feel like you're getting any contact with them, sometimes it's important to say, look at me when we're talking. I don't get the feeling that you're hearing what I'm saying. And sometimes, you know, we get into our own little habits and our own little ways, and we need somebody kind of just to pull us up short and make us think about what we're doing and do it better. I think it's a mistake to assume that somebody isn't listening. We are listening. Not all of us listen as well as we might. Sometimes we have bad days and we just want to get through to the end of the day because we're human. But I think that if you feel uncomfortable with it, you talk to the doctor about it, and if it doesn't change it, then maybe it's time to find somebody else. Okay? But that may be an increasing issue because Medicare have said that by 2014, we have to have a substantial amount of our practice on electronic records. I don't know what I'm going to do. So I'm a pencil and paper person, what can I say?